Assalamu alaikum. Good morning, everybody. Thank you, Mr. Chairman, for the invitation. Would like to get through the adjacent segment disease in the cervical spine, and we'll talk about it as do we have a fusion problem or it's a natural history. Dr. Wong has already gave us a few points about the possibility of adjacent segment disease, so this is going to be like a continuation of the same talk. So I would like to get the voting for the case. So please share me with your opinion regarding this case who came to my service about 6 months ago. He's a 75-year-old male patient who developed a neck pain and shoulder pain radiating to the right arm with a severe stabbing pain. And he is known case of hypertension, ischemic heart disease. He had a surgery done about 6 months prior to the presentation. He has standalone cages being placed at the C5-6 and 6-7, and it was a standalone. He was okay initially, but he had a recurrent of symptoms with a severe arm pain. On examination, he has tenderness as well as Sperling test positive on the right side, which is more of a radiculopathy sign, and neurologically he was okay. So looking at the initial images, he had post-operatively immediate one. It was sort of a reasonable alignment at the start, but within just a few months, he started to drop to the front, where he started to have a kyphosis, and the dynamic views showed some lithosis at the top at the C4-5 that was dynamic on a flexion extension. And this is the MRI and the CT for a complete evaluation. And then we'll come up to the voting. So please use your phone to give us the vote for whether to go conservative and nothing to do, just with physiotherapy and the complete conservative management, or to manage that adjacent level with a total disc replacement. Or the third option is to revise the anterior procedure with an extension higher up with an LCDF and correction of the kyphosis, or to do combined anterior or posterior. So please try to make your voting throughout the lecture, and we will look at the votes at the end. So cervical spondylosis, it's a common problem. We get to deal with this problem on a daily basis in this spine practice. And if we choose to go from the front, we have the two options, whether to do an ACDF or a disc replacement. The ACDF is our gold standard and has been running for more than 50 years. And the only problem that we might blame is the fusion might increase the mechanical stress on the adjacent level, and that might accelerate the degenerative process and might end up with what we call it adjacent level disease. So the question is it real or just a natural history? So Hellwell-Brand gave us his series early in 1999, about 374, and he followed up those patients from 10 to 20 years. And the incidence being found to be about 25% over a 10 years time. And they've noticed that it happens more in elderly, which is the cervical spondylosis. And more interestingly is he found that the adjacent segment disease is less likely to occur when you have a multi-level fusion. And the reason for that, he thinks that when you do multi-level fusion, you're actually protecting those levels for developing a spondylosis, and that follow the same criteria, that it happens more with elderly and more of a natural history. Cadaveric study gave us two different conflicting data. Some of them was supporting the possibility of increasing intradiscal pressure and consequently causing a degenerative process, and the other one did not. So radiological studies gave us a different percentage of adjacent segment changes on a follow-up. So in 1994, it's been described as a 50%. On 2004, it's been described to get up to the 90% of adjacent segment disease over a 10 years time. So is it possible to develop adjacent segment disease without having any fusion? Looking at the series talking about the foraminotomy, which is a posterior procedure, we found that in 1990, they described up to 50% of patients who have just a foraminotomy can end up with adjacent segment disease or even at the same level. And more recently, in 2007, Clark reported about 5% only for a patient who developed adjacent segment disease, and only about 0.7 per year who needs the surgical intervention. So disc replacement, there's many articles talking about disc replacement to lower the incidence of adjacent level disease. Is that true? Looking at this systematic review, this one published in 2015, they looked at these 9 RCTs comparing the total disc replacement, and they found that the reoperation rate for adjacent level disease after the use of disc replacement was about 3%, and the ACDF was about 6%. So there's a double percentage, but it's still comparable. Adjacent segment disease was also looked at in this prospective analysis for a 93% of patients, who was followed up for 8 years, comparing the Bryan disc, cervical disc with an ACDF. And they found that 19 patients who developed an ACDF, the adjacent segment disease in the ACDF group, compared to the 13 patients in the disc replacement group. And both equally has a good clinical outcomes, and both group has a reasonable outcome. And they've noticed that the increasing patient age was the main cause, and it was comparable in both groups. Another data was published in a systematic review about the comparison of the disc replacement with the ACDF. It was a systematic review, looked at about 28 studies was included in this analysis, and total of about 4,000 patients, and they found that it was a favorable outcome among the disc replacement group. And the reason for that is that they got more neurological improvement and lower rate of adjacent segment disease. But both groups were comparative in terms of operation time, blood loss, and the outcome, and the reoperation rate. So is there something we should look at when we plan for the surgical procedure? This article was talking about the disc space. So they've looked at this 116 patients, and they looked at the disc height, sagittal segmental alignment, and the whole global cervical alignment called sagittal alignment of the cervical spine. And they followed these patients for about 2 to 3 years. And they've looked at the plain x-rays, and they looked at the possibility of having adjacent segment disease. So they have 2 groups, adjacent segment disease and non-adjacent segment disease. And they've noticed that about 28 patients developed adjacent segment disease, and the post-operative and final follow-up of the disc height in the adjacent segment group was significantly higher than the non-adjacent segment, and was statistically significant. And additionally, post-operative disc height was significantly correlated with the post-operative or even a final follow-up segmental sagittal alignment. So the clinical Another study looked at the 10 years outcome of the ACDF, and it looked at about 177 patients who had an ACDF followed up. They've noticed that the vast majority of patients who developed adjacent segment disease were the spondylosis compared to the trauma or a herniation. And the radiographic evidence of adjacent segment disease was present in 90% of the cases, and the clinical symptoms were only present in about 19 patients, and less than 7% needed further surgery. And they've concluded that the multi-level fusion plate to disc distance less than a 5 millimeter were found to be more important predictor for developing of the adjacent segment disease. So in conclusion, the evidence that cervical fusion causes adjacent segment disease is not yet clear, but conversely, there is not a sufficient evidence to say that the fusion is not associated with accelerated spondylotic disease. And among the risk factor is for development of ACD of the adjacent segment disease is the disc height by over-distracting the disc. And at the time of the ACDF, spondylosis, multi-level fusion, and plate-to-disc distance less than a 5 millimeter might be a predisposing factor for adjacent segment pathology. So to conclude this debate, we require more adequate and long-term randomized controlled trial with a good follow-up. Otherwise, we will continue to do what we call it, whatever feels right, we're going to do. So with this, I'm going to finish my talk, and then we'll get to the voting. Can we show the voting results? Do you have the ability to show them? Is that available? All right, so can we just raise hands for the number one, conservative treatment and nothing to be done? All right, so we got like 6 among the audience. So number 2, revision with a disc replacement at the adjacent level disease. Who would like to go with that option too? So we've got 3. And number 3, who wants to revise with a correction of the kyphosis with additional ACDF from C4 down to C7? Can you show up hands? Seems to be like 20. And the last option, combined anterior and posterior. Great, so that is more, about 20 maybe. So we will go more with the last 2 options. So this is what I've done, and I hope it's going to be okay. Nobody knows over time. Thank you very much.